Again, welcome everybody. Thank you for joining us for the Systems for Action Research Program Research in Progress webinar series. Our latest edition today features some new findings from one of our S4A research projects. Our team based in New York City at New York University will be describing findings from their study looking at the role of multi-sector early childhood development partnerships in addressing pediatric health and social service needs during the COVID-19 pandemic. For those of you who might be joining us for the first time, welcome. Systems for Action is a signature research program of the Robert Wood Johnson Foundation. And our forte is studying innovative ways of helping stakeholders in medical care, public health, and the social services sectors work better together by aligning the delivery systems and the financing systems that support those different sectors, helping them to work together to advance the cause of health equity here in the U.S. Our program funds studies all across the U.S., testing a whole variety of innovative ways of helping to connect those systems that operate typically in a siloed fashion in medical care and public health and social services, helping to integrate financing, helping to integrate delivery strategies, staffing, governance, many different ways of helping these sectors work better together. As I mentioned, today we'll be hearing from our research team based in New York City, led by colleagues at New York University, describing their work in studying multi-sector early childhood development partnerships. So with that, I'm going to turn it over to my colleague, Carrington Lott, here at the National Program Office for S4A based at University of Colorado, who will introduce the rest of our presenters for today.
Good morning, everyone. And just as a little I guess, agenda setting, we just heard our welcome from Glenn, and then we'll throw it over to our team at NYU to give their presentation. And then we'll reserve the last 10 to 15 minutes for Q&A. So if you have any questions that come up at any point during today, please use the Q&A box at the bottom of your Zoom screen, and we'll make sure we address those questions at the end of today. So we'll be hearing from Margaret Paul, who we call Maggie. She's an assistant professor in the Department of Population Health at NYU Langone, which I had to practice pronouncing before we started. She's a member of the section on health choice policy and evaluation. And after Maggie is finished with her presentation, we'll hear from some commentary from Suzanne Brundage, who is the director of population health at Pediatric and is based in Seattle, Washington, but she used to work with this team in NYU before she transitioned. So with that, Maggie, I'm going to stop sharing my screen so you can share yours.
Okay, that sounds great. Hopefully everything will work beautifully here. Okay, can you see that?
Looks great. Thanks.
All right, great. Okay, so I want to start by introducing the other members of my study team who are here and with me today, and we may hear from them later during the Q&A session, but Dr. Carolyn Berry, Rachel Masser, and Kayla Fennelly have been working with me. We've been a team investigating this particular project, but also a range of other social needs screening and referral projects over the past few years. So the Partnerships for Early Childhood Development Collaborative, or PECD, as I'll call it today, was founded by the United Hospital Fund in the spring of 2017. At that time, it included 11 New York City-based clinic community partnerships. At the time of the start of our S4A study, it included 7, and that's really the sample that I'll be talking about today. But the collaborative-wide goal was really to strengthen multi-sector partnerships for the good of childhood development throughout New York City, and there was a special emphasis on children under the age of 5. And I'll talk a little bit about the overarching program model that all sites used. Of course, there were individual site level variations, but all followed the same general model of social needs screening and referral. Here I've listed the organizations supporting both the programmatic work and our evaluation. And of course, today we're here to talk about findings from our RWJ S4A study in particular. anyone from PECD on the call today will see that this is a little bit of an outdated list. This is from prior to the pandemic. In terms of community partners, I know that there's been some turnover there, but I wanted to give you all a sense of who we were working with in this effort. And so these were all hospital-based clinics, but that ranged really, really broad range of size, from St. John's, which is a small a clinic affiliated with a hospital system in Far Rockaway, to New York City Health and Hospitals site, which is, New York City Health and Hospitals is the largest public hospital system in the US. And so the context for each of these programs really varied greatly, even though they were all located within New York City. The first 4 components listed here were really our planned study components prior to the pandemic. So we worked with sites early on to establish a core set of process measures. We helped them with their logic models and did some formative evaluation work during the early phases of implementation to help improve the programs before they really launched at full scale. Once programs were established, we conducted a time-limited what we call a deep dive process evaluation for sites that were selected based on variation in strength and history of partnership and available resources to them. Those included 2 different rounds of interviews and site visit observations. And then, of course, we wanted to assess outcomes via a pre-post caregiver survey. Right before we were ready to assess outcomes, the pandemic hit. And so the S4A work that we are going to be primarily focused on today is really an examination of the impact of the pandemic on the collaborative as a whole, including caregivers. And today I'll share with you some of the work that we've done to assess caregiver perspectives on the program broadly defined, so across these multiple sectors, and how that really worked to meet their needs or not. As I mentioned, our S-rate project is really focused on the impact of COVID-19. We received a supplemental funding under that specific call. And our approach to doing this is really mixed method. So we're analyzing some process data that we got and that sites have been collecting throughout the pandemic, or throughout the collaborative rather. We are going to talk today about what that data looked like during the pandemic. We're also going to present information from caregiver interviews with some supplemental information that we gleaned from interviews with leadership, providers, and staff prior to the pandemic. We are also going to share a little bit of our early findings from photo elicitation interviews with caregivers to understand on an even deeper level their perspective on how their health is impacted by their community. And then I'll talk about some upcoming work that we have with a broader network of stakeholders. So why do this work in pediatric care? I think the ultimate goal of this program is really to use the clinical setting as a touch point to identify and refer families with social needs to appropriate resources in the community. We know that poverty is disproportionately experienced by children in the United States, and even though low-income families are less likely to attend well-child visits, most low-income children still attend at least some of the 13 well-child visits recommended between birth and age 6. We know that early childhood is a critical time for intervening on upstream risk factors, and also is a chance to intervene at the household level that moves beyond just the patient, but also to their caregivers and other family members potentially. And that's something that we hope to look at down the road as well. And finally, just want to underscore that pediatric clinics are especially well suited for this kind of work because prior to the dawn of social needs screening and clinical care, they've already been spending a lot of time partnering with local community-based organizations due to other early childhood referrals. And so, this isn't foreign territory to them. Pediatricians and staff at these clinics really are well-versed in developing and maintaining relationships across sectors in the community. The overarching program model is so simple. You would think, it would just be the easiest thing in the world to do, but the basic idea is that you identify social needs in the clinical setting. Clinic staff act as resource navigators to connect family to local community-based organizations with resources to help those families. And then the community-based organizations report back to the primary care clinics what happened to all of the referrals. And so this was the overarching plan in each site. Again, the details of the programs varied across the 7 sites, but this was the overarching model for the program. Our research questions initially were really to understand, whether or not this program, broadly speaking, across all sites was working to reduce needs and to identify some effective implementation strategies through our qualitative work. But then, of course, we also now need to focus on how the pandemic impacted this network, including parents and families. I included this slide just to really show you where we were focused. So I'm not sure if you can see my mouse at all, but we'll really focus on understanding this loop all the way to the left that goes from unmet social needs to connection to resources and back again. We really were focused on that, those specific linkages and really collecting data to study that in particular. You can see here the red box represents the study activities that have occurred after receipt of our S4A grant. And so we had been engaged with sites, and this is really a credit to the United Hospital Fund and to Suzanne, who's joining us today and involving us really early on in these projects. So we really have by the time we're out evaluating outcomes, we've already established a really clear picture of the program in each site and have a good working relationship with the teams in place in each site. But then we had to adjust course due to COVID-19. And we really, it's not an exaggeration to say that we were planning to launch our survey right at the start. I think we had planned to launch in mid-March or late March of 2020. So we kind of had to backpedal a little bit, and we did an initial quick series of interviews with sites to understand where they were and whether or not the program was still up and running. And then we developed and regrouped, and all of us collectively came up with a plan to launch the survey at a later date. The blue arrow is sort of where we are now. We're in the midst of our photo elicitation interviews with parents, which we'll talk about later. And then after our last and final piece will be system level interviews. And I'll talk about the purpose of that a little bit later as well. Okay, so on to some of our findings. We, as I mentioned, developed in partnership with the sites and UHF a series of process measures to capture program implementation. If you think back to that loop that I showed in that model that we were really focused on, these measures are intended to capture that. So of course we wanted to know the screening rate, of those targeted, how many caregivers were actually screened for social needs in the clinical setting. We wanted to know of those screened, how many were positive. Some of the formative evaluation work that we did just after the launch of the first iteration of the programs revealed that we really also needed to capture false negatives or missed positives. It came up in that part of our work that in talking with staff, we realized that some caregivers didn't feel comfortable reporting some needs on paper, but used the screening as a way to launch a conversation with a trusted staff member or a provider about actual needs. And so so incorporating that then again into the tracking data is helpful, was deemed helpful by everybody involved. Of those with a need, at least one need, we wanted to understand the referral rate. So what proportion of those individuals were actually referred to services. Of course, the other piece of that is understanding the refusal rate, those who identified a need but were not interested in being referred to services. Of course, wanted to know about service provision. And then finally, pie in the sky, as it turned out, we were hoping to capture referral feedback. So of those referred, how many, for how many the clinic received an update from the community-based partner. We call this sort of closing the feedback loop. This is just a real honest look at the data that we have, and it is what it is. You know, the blanks are missing data that sites were not able to capture. Of course, I removed site name here, but it's really important to know. I want to underscore that sites were trying to capture these data points. So this is not for lack of effort. But you can see, especially as we move across sectors towards the right of this table, it becomes tricky to capture some of these measures. And so, so I don't want to spend a lot of time on this. I could go on and on. Every little number here is a story, but I think it's important to know, as with a lot of different parts of our study, the data proved to be complicated. So even something as simple as the screening rate, you can see that some sites weren't able to define their denominators. And this is because, of course, if you think about clinic workflows, you have no-shows, you have walk-ins, and all kinds of other things that can disrupt the target population in a given day at the clinic. And so something that we thought would be really simple, as it turns out, was actually quite complicated to capture. And that only kind of increased in complexity as we move from left to right here. So I just want to make it clear that the sites were doing everything they could to get this data, and even had some grant support from UHF and their team of funders to do this work, but it still was just a really complicated thing. Site B, you can see, has data coming in from 2 different systems. So for most sites, this was a challenge. Okay, so caregiver surveys. I think that one thing that I wanted to underscore on this table is that the sites that were able to successfully capture referral feedback, by and large, with one exception, were doing so just via meetings. So there's no like smooth data system linking these sites together. This is just, you know, like hardcore partnership in action, people meeting regularly, talking with each other and talking about individual cases. And so that's how these fields are populated. There was one site that was able to come up with a data sharing system with their CBO partners, but that was the exception to the rule during this grant period. We also conducted caregiver surveys, and I have, I'm going to spend probably the most time talking about this because it's certainly the richest data source for us right now. But we did phone-based surveys. Our team administered them to caregivers. So the staff at the clinics would get consent for our team to contact caregivers and send us a referral sheet, and then we would reach out to them. And so we did phone-based surveys at 2 time points. Caregivers got a modest incentive, and at first time point, we had 209 individuals complete our survey, which represents about half of the parents who agreed to be contacted by our team. And then we had a 62% follow-up rate for a sample size of 129 at post-test. So that's 129 individuals who took both the survey at time 1 and time 2. The vast majority were female. We had a lot of individuals, caregivers who reported speaking Spanish only and identified as Hispanic or Latino. And there was a lot of Medicaid. And when I say caregiver throughout this, 98% of those surveyed identified as being the patient's mother. There were on average 2 adults in each household and on average 2 children in each household. And not surprising because this was skewed toward a younger age group, but the average child age was 4 years old. And I just want to, you know, I think the average number of adults and children is important to focus on because some of the resources that we're talking about, you know, thinking about access to food and so forth are actually, you know, could be potentially beneficial to the entire household. And so just going back to the importance of doing this kind of work in a pediatric setting and making the cross-sector connections at the household level, I think there's a lot of potential for impact there. So we know that not everybody, we know from our survey that everybody who we surveyed was in fact screened, but just under 70% remember being screened for non-medical issues. But of those who remember being screened, they reported feeling very comfortable. And the majority of people who didn't remember being screened reported that they were being that they would be very comfortable answering questions about non-medical issues in a clinic setting. And so that's important to know. I mean, this is a really, this topic can be sensitive for people. And so it was good to know that they reported a high level of comfort in the survey. This is echoed in our interview data, which I'll talk about in a little bit. And I think now is starting to shine through in the literature as well. So I think we can now say it's well established that caregivers in general feel comfortable with this type of screening about non-medical issues happening in a clinical setting. Of those who remember being screened, 57% recalled that someone at the clinic spoke with them about some resource navigation, did some resource navigation work to connect them to local organizations. And then you can see it's whittled down to, of those who reported making contact with local organizations, most received services, but at this point, we're talking about 33 individuals. So you can see, at every point of data collection, the sample size gets a little bit smaller. And Rachel created a beautiful flow chart that I couldn't fit on this screen, but as you can imagine, it's complicated. The flow of caregivers through this cycle is complicated, and especially when you're asking them to recall certain things. But our general takeaway from that line of questioning was that even if they didn't remember actually being screened, they reported being comfortable, and those who were screened certainly were comfortable being screened. So at the top of this, you'll see that two interesting things. So from time 1 to time 2, and again, this is both time points occur during the pandemic. The total needs reported decreased by about 1 need, and that was a statistically significant change. And we also, though, see that the number of families with 0 needs decreases as well. So more people have needs, but overall fewer needs than they did in the very early stages of the pandemic and prior to connection to services through the program. The needs varied. There were a lot of them. This is slide 1 of 2. So I'm not going to spend a lot of time on each of these slides, but you can see in general, things are moving in a downward direction, the exception being a couple of variables related to housing issues. So you see that pests increase, other environmental issues in the house increase. But overall, other than that, we saw that needs were sort of decreasing across time periods. In terms of caregiver well-being, and again, this is really, people who identified as a mother predominantly, well-being stayed the same. There were no statistically significant changes for concerns over child development, parenting self-efficacy or perceived stress, but we did see a statistically significant drop in PHQ-9 scores from time 1 to time 2. Which is sort of mirrored by the decrease in total needs at the household level from time 1 to time 2. I have a few slides here, I think 4 on impacts of the pandemic. So once we realized that COVID-19 was here to stay, we of course adjusted our surveys to assess caregiver needs related to the pandemic. So I say that because these are not necessarily things that we expected to change as a result of the program, but we felt it was really important to capture context. And indeed, we see that there's a lot of job loss and financial insecurity and some elevated concern about community violence. We also, heard about household members being hospitalized and dying from COVID-19. And of course, disruption in childcare was pretty prevalent among this population as well. Overall, people felt both distressed and optimistic at both time points. So people were experiencing at least some distress, but we're at least somewhat optimistic about the next 6-month period getting better in terms of their and their family's well-being. And so, so it's a complicated time. I'm sure everybody on this call can relate, but that really came through in our survey as well. I should say that the survey, you know, we were interviewing caregivers about this, but we were also asking them about, you know, their perceptions of their children. And so we do have, you know, we do see that a lot of them were very concerned about their child's education, you know, their economic future beyond the pandemic even, and the housing issues continued. You know, we asked about housing in several different ways across the survey, and that really came through as a critical issue for families. And I'm highlighting it because it's also, we know from our clinic CBO partnerships, one of the most challenging issues to address, especially in a place like New York City, but I think in cities across the US, housing, low-income housing supply remains low. And so this was something that we had some clinics even stop screening for, you know, housing needs beyond the need to get on a wait list because they were unable to really do anything about that. And then this is our final slide on the impact of COVID as captured in our survey, but we see that you know, this reflects the material that we've covered so far, but just some more detail on specific concerns about family. And so given all of this, we were sort of surprised to see that PHQ-9 scores went down by a point and that needs went down by a point. But I think that that we have some sense of why that might be. That came through from some of our other work, namely that clinics were doing a lot to connect with families and connect them to resources, and community partners were doing a lot to secure additional resources to rise up and meet the needs of families across sites rather. We did a series of caregiver interviews across 7 sites. So we had about 2 caregivers from each site talk with us. These were done in English and Spanish. All of the interviewees identified as mothers, which is pretty reflective of our survey sample. Most reported having multiple children, and just over half were employed in some way. They were very happy with their clinical care. I didn't include that on our in our tables on the survey data, but we know from a series of questions that overall caregivers were very happy with the clinics that they were being seen at, and very satisfied with the services and the staff that they encountered there. As I mentioned, came through in the survey data as well. Most felt comfortable answering social needs questions in a clinical setting, and most felt very strongly that they wanted this bridge across sectors to be supported by staff. So they really felt like they needed some real resource, you know, human-centered resource navigation to make the jump to connecting to a community partner. And so that is something else that is a real key finding from this part of our work. Just the value that caregivers place on that human connection is very high. Even with this, however, caregivers acknowledge some post-referral challenges. And this is not surprising, but just important to note that even if all of this works really well and the resource navigation is successful, things like CBO hours can still pop up. And so I think there is some work that can be done on the implementation side to, you know, for example, maybe incorporate a discussion in the clinic about, you know, work hours and adjust referrals based on CBO hours. You know, all of that requires more and more manpower, but just something that came out is just, even if you're able to make the connection, it doesn't necessarily happen because of a variety of aspects that are totally reasonable and pop up in everyday life. However, once connected caregivers really viewed the CBOs as another resource and connected with the staff working there. And some of the caregivers that we talked with had even referred some of their friends to get services. People who weren't, you know, seen at the clinic necessarily, but who were just living nearby, sent them to services for their, just based on their experience as well. So that was great to hear. And then finally, I want to end on this part of our findings with underscoring the fact that we're thinking back to that loop of unmet need to connection to services, back to unmet need. Most of the mothers who we spoke with who had been connected to services reported that they still required assistance for new and recurring needs. And so I think, in terms of implications for implementation, I think just understanding the importance of rescreening families, it may be annoying to some caregivers. There are ways to make it less annoying and allow them to opt out. But I think offering the rescreening at well child visits makes a lot of sense based on what we heard from caregivers. Okay, so I'm going to talk about this last component of our study and then go into some cross study findings. So we are now in the midst of conducting photo elicitation interviews with caregivers. I'll call it PEI for short. It's an interview method that allows participants to really drive the interview and discussion. So the general idea is that you provide participants with a camera. We used to actually send them cameras. Now we have people take pictures on their cell phones and just text our team the images. But the idea is that you give them a general prompt and ask them to take a range of 8 to 20 photographs is typically what we do with our team. And just the interview then is a meeting with the caregiver, and they arrange the pictures as they like and sort of talk their way through their story. And so for this, we asked them to take photographs of things in their community that helped them maintain the health of their families, or made it harder for them to maintain the health of their families. And so I'm going to share just 4 photographs from a recent PEI session with you today. The one on the left here is a photograph that a mother took of her apartment building, and everything that's in red here you see is something that we flagged as negative. That's not a judgment that she put on it, but we flagged that as something negative, whereas green is positive. So you can see that she really complained about noise. She has 2 little kids at home, as do I. Anyone with little kids knows that, when you hear people honking outside, it sort of makes your heart stop, especially if they're napping. And so she really complained a lot about the noise pollution, but said that she loves walking outside of her front door and feeling like she's in this vibrant community with people walking around and the train nearby that gives her access to the rest of the city. And so she really liked where she lived, even though the noise was driving her nuts. And then we spent a little bit of time talking about strategies that she was using to address that. And then on a more serious note, a housing issue came up with this mother that had not been identified before, which is that her heat doesn't work well. I think she said it doesn't work well, but it sounded like it sort of didn't work at all. And so she had purchased a few space heaters to heat her small apartment, and was especially, concerned about her kids at night in the winter time as a result of this housing issue, and had been in touch with her landlord, and it sounded like she could use some additional support there. So we referred her back to her clinic team to get connected. But this is the kind of thing that just a good example of getting at another layer. She didn't see that as a housing issue, but clearly it is. She really loved the park nearby for everything from playing with her kids to meditating without her kids. And then I didn't include them all here, but I think she took four pictures of two grocery stores and 2 different specialty food establishments. And it just became apparent during the conversation that Rachel and I had with her that she really found a lot of joy in preparing healthy meals for her family and valued access to food, and really appreciated that even the bodega that she included a picture of, this is not the bodega, but the bodega on her corner took food stamps. And so she really, really valued that as well. Okay, so some of the, I'm going to just spend one slide here talking about our general cross-study findings on implementation. This is not limited to our S4A grant, but it pulls on some of the study activities that we had done prior to the pandemic, including a lot of site visiting and interviewing with staff and providers. So we know that this work is possible. So doing this work well is possible, but it requires real multi-sector partnership that is built on trust, open communication, and ideally financial agreement between the health entity and the CBO entity. We found through our interviews that, of course, this is no surprise, but there's a real power imbalance across sector, from health to community-based organization and the service sector. And so especially, we found that the programs worked especially well in sites that had that relationship in place. And I'm thinking primarily about judging them on ability to sustain the program. This importance of financial contracts really came up in our last phase of interviewing with sites right before the end of the grant period. And when we started digging into the concepts of sustainability, we found that the sites that were most likely to sustain were ones that in which money was flowing from the hospital system to the CBO network that they were partnered with. And finally, you know, clinics are very busy places, CBOs are very busy places. And so, you know, adding on to the work that these entities are doing already is really difficult, but can be done thoughtfully. And I think, you know, the sites that were in regular communication with one another were even able to figure out how to connect that last piece of information on referral feedback into the system. And so, yeah, I think that a lot of like thoughtful planning and communication has to go into these multi-sector partnerships, but we certainly did see some shining examples of success stories in the collaborative. Of course, establishing trust with caregivers of these patients is also possible, but similarly needs to be approached in a thoughtful way. And the thing that I'll just take the opportunity to underscore once more is that the staffing for these programs really matter. So we know that especially when staffed by members of the local community, you know, staffed by someone that the mothers / caregivers felt that they could relate to, that really went a long way to fostering program engagement and successful connection to services. Of course, tracking implementation is challenging, and particularly across sectors. And so that's sort of an area for future research. I don't know that our team will be doing that, but I think if this sort of screening and referral program is really to continue proliferating throughout the US, there really does need to be really close attention paid to cross-agency communication and data platforms. At the time of this study, we, you know, on our final round of interviews with community-based organizations, we heard a lot from them about, you know, there were these two social needs screening software platforms that have been adopted by various health organizations, health systems in the city. And so because that was not a coordinated, thoughtful, you know, effort on the part of the health systems in New York, now the CBOs serving patients of these health systems have to figure out how to use 2 different or 3 different social needs screening referral platforms in order to effectively communicate with their partners. And I know that it's hard to coordinate on issues like that, but it has been done in various places throughout the US. I think North Carolina is an example of that. And so more attention to how to ease the burden, particularly on kind of chronically under-resourced CBO staff and overworked clinic staff would be something worth doing. And then, of course, as I mentioned earlier, the contextual factors really impacted every aspect of implementation and impact, we suspect as well, although our sample size was too low to really measure clinic-specific impacts on caregivers. We know that the clinics and their community partners adapted to meet the needs of families by and large. Practically overnight, they were making adjustments to the way that they were screening, and really, you know, at a time where we at one point thought that this entire collaborative might stall and that all of the screening would stop, they really actually increased outreach to families. And we know this just from staying in touch with the sites, but I'm hearing initially that some sites were taking this as an opportunity not just to screen people who were, you know, coming in, so to speak, for telehealth appointments that day, but really to reach out to all the families on their lists and to not just do that, but update public facing resources and clinics even, reached out to other local institutions, other CBOs that they hadn't previously been partnered with to just really reinforce the networks for their families. So it was really kind of an amazing response to see. And on the other side, we saw that families actually participated in screening during the pandemic, which was just an indicator that they really perceived these programs as a real valuable resource to them. As I mentioned, these were 7 sites in the same city, but they all had very different partnerships and populations that they were serving. And so while local and state policies could, certainly impact, especially when we're thinking about like reimbursement mechanisms for this kind of work, that's certainly an important piece of it. But I think focusing on the importance of local context is also helpful when thinking about how to develop an effective program. And then, of course, it's amazing to see a decrease in need and depression scores among mothers in our survey. We had a large number of variables that did not move an inch, a lot of findings from our survey. We measured a lot. What I showed you here is really just the tip of the iceberg. So we did have a lot of non-findings. I want to underscore that, but we did see a meaningful reduction in need and depression. We saw that telehealth, and I know that there's a lot of work going on to understand equity issues in telehealth, but among this network, it was by and large perceived by caregivers as a positive adaptation, especially at a time when they were not interested in using public transit or not able to use public transit even to get to their appointments because of the pandemic. The show rates for telehealth appointments are close to 100%. Not all well child visits can be done virtually, of course, and sites were creative in how they adapted clinic workflows to adjust for in-person visits during the pandemic. But some of the telehealth adaptations may be maintained going forward. So some sites, 2 sites in particular, reported that they really liked screening for social needs prior to the visit, so that data was in their system, accessible to them, and then they were really focused during the appointment on the resource navigation part and not trying to do the screening, and referral part in the same visit. So I'm interested to see how that evolves over time and whether or not that continues to be done by phone. Some sites, even before the end of the grant period, were back to in-person screening, and we're fine with that. But I think it's nice that sites see this as an option now. And I think we're going to use our next phase of work to understand the long-term changes of all the pandemic on this network in New York City. So we know that New York City, like everywhere, experienced a spike in need. We also saw, though, among our collaborative that there was an increase in resources that community-based organizations were able to secure to meet those needs in most cases, but that some, needs such as housing remain a challenge. So I'm interested I think that's one of the main focuses of our interviews with a broader network, is just to really understand long-term impacts and whether or not there's potential to maintain some sort of latent capacity to adapt to a pandemic in this network should it arise again. So as I mentioned, we're going to conclude our caregiver photo elicitation interviews and analyze data from the qualitative work that we've been doing. We're going to finish our last study activity here, which is qualitative interviews with our broader network of stakeholders, and that's going to include payers and also people at local and state public health agencies interested in this work. We also have some planned dissemination activities coming up, and I listed conferences just in case anyone here is going to go to Academy Health. I think it's actually in person, barring some other, variant disrupting our plans. And then we are partnering down the line. We hope to partner with a former PECD site on a couple of related studies to this. So one examining a public health core CHW-led screening and referral program, and another to assess best practices for this kind of work in adolescent primary care settings. Those are very much in the planning stages now. And then we'd also more broadly like to explore the role of public health agencies in assisting small or solo primary care practices with screening and resource navigation, because I think we know that if it's done well, it can be quite resource intensive and essentially not feasible in these smaller practice settings. Okay, so I'm going to turn it over to Suzanne. I'll stop sharing. Or maybe I'll keep this up. Suzanne, do you want me to keep this slide up?
No, that's fine. Thanks.
Okay.
Thanks so much, Maggie. And thank you for the great presentation. Hi, everyone. I'm Suzanne Brundage, currently Director of Population Health at PM Pediatrics, but was the Director of the Children's Health Initiative at the United Hospital Fund in New York. And as such, really helped lead the collaborative and the network that Maggie has been sharing. And just first want to say kudos to the NYU team, but really all of the participants in this collaborative for continuing with the work in the midst of the pandemic and pivoting. As Maggie said, it's really extraordinary and a lot to be proud of. So I know we're short on time. I'll just tee up a couple of reactions from myself, really framed around some of the original design theories that led to this clinic, the kind of health and social service collaboration and what I took from the presentation. So, the first one is this partnership was squarely focused on children ages 0 to 5. It was really pointed at early childhood development, and that was because of the emerging and growing science around the importance of early adversity and how it impacts lifelong educational and health outcomes. And so I think people on this webinar really appreciate that science. I will say, though, that just looking at the survey results that Maggie presented, particularly around caregivers saying that they had some or extreme distress, 65% of parents reporting that, is maybe not surprising, but certainly concerning for those of us that really understand what a pivotal moment in child development those early years are, and something that as researchers, we really need to track and understand the long-term implications that COVID has had on human development. The second piece of developing the collaborative was really the intention of focusing on those close one-to-one or one-to-two partnership relationships between the hospital systems and the CBOs. I see in the chat some people asking questions about like the social needs platforms and technologies that allow for wide networks and many referrals, which I think certainly have value. But for us, part of the theory, especially in New York City, which is such a complicated health and social service ecosystem, is really that there are a lot of hospital systems or pediatric clinics that are maybe next door to social service providers, but they're neighbors living as strangers. They don't know each other. There's really no understanding of the service array in the community, and that is a barrier to making referrals. So that was sort of the intent of the collaborative, was to overcome that initial hurdle on the pediatric practice. I feel confident to say the work overcame that hurdle. I think what's really interesting based on Maggie's presentation is that piece around the referral loop. And for those that could report on it, over 60% of the patient base, there was some kind of closing the referral loop, even though it was in the context of meetings. Our theory has been that closing the referral loop is an essential part of the process because it promotes further referrals, right? That as pediatricians understand people are making it to the appointments, that they've had a good experience, that's making a difference in their lives, it self-perpetuates the cycle. And maybe that's something the team will look at when they go into those system level interviews. Next, I would just say that clearly the resources to do this work is a huge challenge. It was funded, philanthropically in this case. The whole idea was that as state Medicaid programs pay more attention to social needs, those resources have been heavily focused on chronic illness and chronically ill adults, and not going into the pediatric setting because of this sense that children are predominantly healthy and low cost. So I think the finding around the family-wide impact, and particularly this nugget around the significant impact on the PHQ-9 scores is really, really compelling. And for, would love to see much richer research around that kind of family-wide return on investment. And then lastly, I'll just say, the idea of comfort with screening for unmet needs in the clinical setting, I have no reason to question at all the findings that Maggie presented. I would only caution that we shouldn't all assume that it is a given that families will be comfortable with the screening. In this case, there was a learning collaborative of all the participants, and we spent a lot of time talking about how to build the trust with families and how to appropriately screen families to set up a successful dynamic. And so I would just caution there that I think this shows, it is possible to have high level of comfort, but not a given for those who are starting anew. And so with that, I'll just end there. Thank you so much to everyone who's been involved, and look forward to the conversation.
Thank you so much for that commentary, Suzanne. And thank you, Maggie, for your presentation. I have the privilege of checking in with this research team very often, but it's always fun for me to get to hear how the project is progressing in these presentation formats. So this is their second research in progress webinar, but they will probably have another one in the future where they can share their final findings. So we'll definitely keep you updated from Systems for Action about that upcoming webinar. And with that, let's move into our Q&A portion for today. I do see a couple of questions have come in, and I do want to encourage you to still submit your question if you have one. If we don't have time to address it today, we can follow up with you offline to make sure that we address your question. So there was a question that came in that I want to bring up first, because Suzanne did talk a little bit about the financing aspect of this and how that was philanthropic, but there was a question about the sustainability and the financial aspect of this work that you're doing. Specifically, did hospital systems use community benefit dollars? Did insurers pay for services and staff? And was there a state agency blending and braiding of funds to support a model like this?
Well, Suzanne, you might have some thoughts on this too, but it varied across the collaborative. So some of the sites had, like, their institution had a real mission level commitment to doing work in the community. And so when I say that we selected our, deep dive process sites based on, history of partnerships, some sites have been partners with their community-based organization affiliates for like 40 years. And so whereas some were developed with the resources through this grant and were really brand new, and not saying, one is better than the other necessarily, or, but we certainly saw those sites with the long partnerships just carry on throughout the post-grant period, because they were just used to doing this work. And so they had used the grant funds for some very specific targeted activities and really to bolster their screening and referral efforts in this area, but they knew their partners, and they had these long-standing referral partners. And so sustainability in those places also meant funding a staff person. So not only were they did they have relationships, they had like manpower behind those relationships. And I think that's where the funding piece gets a little tricky, because there frankly are some systems that were engaged in this work, and I think it's not probably uncommon nationally that we're not willing to just like donate internal dollars to this work, whereas some were. And so I think that was like a dividing line. Just the amount of resources available to these screening and referral programs from their own hospital systems varied a lot. And some of those hospital systems were using public benefit dollars to do this. Especially there was the disrupt funds available to some of these sites initially, which was waning towards the end of the grant period. So I think, yeah, I mean, I think that's the piece that everybody is sort of looking to outcome research to figure out. And that's where, you know, focusing on more proximal outcomes that are linked to downstream, you know, effects, negative health outcomes. I think, you know, linking up to some of those existing causal chains could be helpful, because by definition, these screenings are happening at well child exams. So we don't really expect to see dramatic improvements in health. These are by and large healthy kids. Some of the work that we're doing with our partners and planning to do with our partner in this work currently is around linking children to mothers. So, you know, forming mother-child dyads in Medicaid data, for example, to assess household utilization as a result of connection to resources. But I think that it's sort of like open territory for outcomes research. There's been very little done with respect to the pediatric population in particular.
I think we have time for one more question. So I'm going to ask, were any of your findings surprising to your participating sites?
That's a great question. I think that sites disagreed. Like there were differences in opinions about some of the best practices to implementation. So I think I mentioned during the talk that some sites were comfortable continuing with phone-based screening, whereas others really wanted to maintain in-person screening. And so that's just one example. But no, I don't think anything was very surprising. And I think it's because the sites, and by sites, I mean, you know, clinics and CBO partners really knew this population through and through. And at the point at last contact, really when we were conducting our last round of interviews and then later on presenting back, everything we've presented here today, we've presented back to the sites. Certainly the survey data, they weren't surprised by it because they've just been so steeped in it for so long, I think. So that was, I think, a good thing potentially that they weren't floored by any of our findings.
Thank you. So I know we have 2 minutes left and there are a couple of questions we didn't have time to get to today, but like I said, I'll share those questions with our research team and we can follow up to make sure that you receive answers. But thank you so much for your presentation and for responding to these questions. And Suzanne, I appreciate you joining for your commentary. And this Research in Progress webinar series is an ongoing series. So in our follow-up communication where we'll share this recording and the slides from today's presentation, we will also share our upcoming Research in Progress webinars so that you can join for those as well. And then you will also be led to a really, really brief survey after the webinar is over today, just to give us your feedback or to give us some feedback on today's session. And then you can indicate if you would like a certificate of completion for today's attendance, which we will be really quick to return to you if you indicate that you want one. So with that, thank you everyone for joining today. And we look forward to seeing you again for another Research in Progress webinar.
Thanks, everybody.